So I think we can now also continue to Jeroen. So Jeroen, like I said, professor of nursing. It's actually, he's not a cardiologist. He's not directly ablating, but he's taking care, of course, for our patients, actually really managing all the things around in the outpatient clinics and also around ablation. And I think it's also important to mention that he was and is still involved in Adelaide together with Prash Sanders and his group, where I also did my fellowship some years ago. And in this group, we mainly also focused on concomitant risk factors and the management of those around, around ablation, around the management of AF. And Jeroen, I'm very happy that you're here and looking forward to your presentation.
Thank you very much, Dominik, for the kind introduction. And it's my pleasure to talk about a different approach in managing atrial fibrillation and risk factors such as sleep apnea, which we call integrated care. I would really like to tell you a bit more about that in a minute. But first of all, I think Olaf already set the scene about the importance of sleep apnea in the management of atrial fibrillation. But we were really curious to find out how this was done in a European perspective. So recently we performed a survey in collaboration with the European Heart Rhythm Association and with the Association of Cardiovascular Nurses and Allied Professions to really investigate sleep apnea management in patients with atrial fibrillation. So we received 186 responses from cardiologists and nurses and allied professionals. And if we look into the figure, we can see the darker the colors get, the more important the reason was to test for sleep apnea. And what is very obvious is that like OSA symptoms is the most common reason for sleep apnea testing. While if we look at the management of atrial fibrillation or looking into rhythm control strategies, it's only a small proportion of respondents stating that that was an important reason. So there's also what we found from the survey that there's a lot of ad hoc referrals to sleep clinics, about 68%. And there's only 11% who reported to do systematic OSA testing, so referring patients for a sleep test or polygraphy. Now, if we look into the further screening of patients, only 5% of respondents indicated to routinely test for sleep apnea in more than 70% of AF patients, and about 6.7% indicated to test in more than 70% of patients as a component of rhythm control therapy. So these are really low percentages in this survey. There's, of course, a number of barriers to systematic testing, and respondents reported on the lack of collaboration between cardiology and sleep clinics, the lack in skills and knowledge, but also financial resources and workforce. And these are really important aspects that we should look into in the near future. So I think what this survey showed is that there's an urgent need for standardized sleep apnea and atrial fibrillation pathways. Now, if we look into the guidelines, the atrial fibrillation guidelines that were updated in 2020, there's a statement that AF management should be according to integrated AF management. And if we look into the figure, there's actually 4 main fundamentals of integrated care. First of all, the approach should be patient-centered. So we need to actively involve our patients in their care process. We need to engage with them to make sure what is important to them, what matters to them, what they really want, and align that with recommendations from the guidelines. So also we need to educate our patients and empower them and prepare them to undertake self-management in their home situation. Then it's no longer one healthcare professional managing this complex condition, but there's a multidisciplinary team approach where, for example, cardiologists work together with nurses, general practitioners, but also with sleep specialists. It should be important to have them all working together in a collaborative approach. Then we focus on comprehensive management, and the guidelines now state the ABC approach. So first of all, we look into optimizing stroke prevention. We look into symptom control with rate or rhythm control therapy, but also the management of cardiovascular risk factors and comorbidities and lifestyle modification, which is really important. And this can be steered by technology to support this integrated approach. Now we've set up integrated AF clinics where I would like to guide you through this figure. So this is taken from the 2020 guidelines as well, where we have the patient in a central role in their care process, a patient-centered approach, with around the patients in the outer circle, those specialists that can be involved in the management of atrial fibrillation. Interestingly, there's no sleep specialist mentioned here, but these can be involved based on the individual case of the patient. Then directly around the patient, there's a core team consisting of a cardiologist, an AF nurse, the family and the carer of the patient, closely collaborating with the patient to really improve outcomes. And then in the blue circle, this is steered by technology to provide education for patients and their carers, but also decision support technology for the healthcare professionals. So this integrated approach is a multidisciplinary, specialized, often nurse-driven integrated AF clinic, where an intensive, comprehensive AF care program can be provided, where we have the opportunity to do a full diagnostic assessment, so where we can also assess sleep apnea. Then we also aim to initiate appropriate and comprehensive treatment according to evidence-based guidelines. And again, it's really important to engage with patients, to educate them and empower them and prepare them for self-managing their conditions in their home situation. Now, looking at the recommendations for sleep apnea from the 2016 guidelines, these are the upper ones, and the 2020 guidelines, these are down here. They state it's important to look into clinical signs for obstructive sleep apnea. It should be considered in all AF patients. We should consider opportunistic screening for patients with atrial fibrillation, and also we should consider optimal management for sleep apnea. But the guidelines don't give us guidance on how to do this. And in an earlier report, we looked into providing some kind of a pathway to provide guidance in how to screen and manage patients with sleep apnea who also have atrial fibrillation. So we took the why, when, how, where, and who approach. So why is really focusing on maintaining of sinus rhythm in symptomatic AF patients diagnosed with sleep apnea. When this is in patients with atrial fibrillation considered for a rhythm control strategy. Then how is the testing for sleep apnea, and where this could be done in a specialized AF clinic where we provide multidisciplinary and an integrated care approach with communication and collaboration with the sleep specialist center. And who? Well, this is again a multidisciplinary team where cardiologists and sleep specialists work together with specialized nurses in the field of atrial fibrillation and sleep apnea. And this can be this multidisciplinary team approach. Now, looking into the pathway, what we thought would be important is to first do an assessment. So really looking into the history. Are there any sleep apnea related symptoms? Is there any signs on a physical examination? For example, is there obesity with high BMI, or is there uncontrolled hypertension? Did we use sleep questionnaires that indicate a high risk of sleep apnea? Then the next step is the testing. The next step is the management of patients with sleep apnea by CPAP treatment. But then follow-up is also very much important, where we can look into CPAP adherence, for example. Do patients really understand how to use the CPAP therapy? Are they adherent to the prescriptions? Do they have any side effects that we can help them with? But also re-evaluating sleep apnea severity, for example, in those patients who were able to reduce weight. So really looking into this pathway might help to further structure sleep apnea screening and management as part of a comprehensive AF management approach. Again, this can be done in an integrated approach where we combine atrial fibrillation management with risk factor management, such as sleep apnea, where the treatment is provided by a multidisciplinary team, and where we really focus on comprehensive treatment and coordination of care. Thank you very much.
Yeah, thank you very much, Jeroen. I think this integrated care approach, which is of course now also really mentioned in most of the guidelines, certainly in AF guidelines, but also in more and more other guidelines, is really, or seems to be really, really critical, particularly when it comes to the treatment of concomitant conditions, like, for example, sleep apnea, but also like diabetes, hypertension, and a lot of other things. And if I understand you correctly, also education and patient engagement seems to be play a very important role there. So what do you think does a patient need to know about sleep apnea or about concomitant conditions in general when it comes to the atrial fibrillation treatment?
Yeah, that's a very important point. So to start with engagement, it's really also important for us as healthcare professionals to really identify how does the patient look into their condition? What do they know about it already? What is really important to them? And how can we align that with the recommendations from the guidelines? So from that step, I think we need to educate them about, well, let's start with atrial fibrillation. So what is that about? You know, how can we help them in preventing that, or like getting into sinus rhythm by treatment, but also what can they add to improve outcomes, to improve the care. And that is really where their self-management comes in place. So for sleep apnea, for example, it's really important to engage also with the carers or the spouse to really see, are there any sleep apnea related symptoms that have been identified by the carer, for example, but also, you know, if they're already diagnosed with sleep apnea, how to use CPAP treatment, are they adherent, and how can we help them to improve that adherence? I think that is really important to have the patient on board and provide this patient-centered approach, because I think if we have the patient in the center of their care, you know, they're part of the treatment team almost, and that's where we can work on improving outcomes.
Let me be a little bit of the devil's advocate here. So, okay, here comes the question I asked before. Why should we treat them? Why should we treat obstructive sleep apnea unless we have proven benefit? Why do we torture our patients with whatever?
Yeah, what do you think about this, Olaf?
The clear answer is, after SURF-HF, if we torture somebody with positive airway pressure, we need an RCT about safety and efficacy. So, and that's the point here. And if you look, and you have mentioned the guidelines over time. So treatment of obstructive sleep apnea in AFib patients was downgraded because there is a lack of evidence. So at that point, we need some evidence here. We need some good, well done, small RCTs to show safety efficacy. That's it.
Absolutely, yeah. So particularly actually also most of the available data until now is indeed observational, but not randomized. And we of course know from a lot of other scenarios, and then actually coming back also to renal denervation, what you already mentioned just before, that sometimes randomizing patients to a treatment where we initially thought the treatment can be very, very effective, can be very surprising, finally, if we look at the results of those randomized controlled trials. But let me actually just ask another question. So now at the moment, we are mainly focusing on just isolated sleep apnea treatment. So we are just focusing on the treatment of sleep apnea. It might actually change a little bit when we position sleep apnea as one component of a combined risk factor modification program. And just let me extend this a little bit. So the recommendation to treat concomitant risk factors in the AF guidelines is very, very high. Yeah, so this is not downgraded. This means to be very, very relevant. And this is mainly based also on the data from Adelaide, but also, of course, from Groningen, Maastricht, and some other centers. So the thing is, what is the role of the management of sleep apnea when it comes to combined risk factor modification programs in patients with atrial fibrillation. So do we actually think that we can manage, for example, hypertension without treating sleep apnea in an AF patient who has severe sleep apnea? So how do we think about this?
It's a good question. First of all, I think we do need combined management of risk factors. But if we look at single risk factors and coming back to sleep disorder breathing again and the SAFE study. So I think one of the lessons we have learned from the SAFE study is that we overestimated the effects of a single risk factor before. So, and by treating sleep apnea for at 3.5 hours at night, we do almost nothing to the patient. So that's true. We need a combined approach to work on several comorbidities.
Yeah, and then maybe also now for Jeroen. So in Adelaide, of course, there was this combined risk factor modification program performed, and sleep apnea was always in all of those interventions actually one component. So can you maybe just tell very briefly something about this?
Yeah, I think, I really agree, to start off, it's really important to investigate, like, why would we treat them? If we have the evidence, then we can further build recommendations on that. So I'm referring to the sleep apnea. But looking at the studies done, so if we, for example, have the opportunity, or if the patient has the ability to reduce weight, reduce their blood pressure, and with that in line, reduce their sleep apnea, we already have achieved something, and maybe that is what Olaf just said, like, if it's just then back to 3 hours a night and we don't have to treat them with CPAP, then that might be something. So I think it should be a combined approach. So not only like an isolated risk factor, but it's all hanging together, I think. And that's why we also focus on this comprehensive treatment.
Yeah, and this would be then also, of course, in line with integrated care approaches, where also interdisciplinary teams actually work together to actually make this combined approach, holistic approach, almost actually possible, right?
I was just going to say, because it's not easy to reduce weight and to keep that going. So patients really need a structured follow-up and guidance with that, and that also is accounts for the other risk factors.
Let me add something here, Dominik. So at least for Germany, we will not get to this approach. I'm again devil's advocate here, because thanks to you Australians, we earned your DRG system here. And by doing a screening for sleep disorder breathing, within 3 days of hospital stay, we end up with a DRG for sleep apnea and not for some EP studies or cardiac intervention or so on. Still, we have this burden, and so we are avoiding sleep testing in patients with 2 or 3 days hospital stay. So, and that's the majority of our patients. So, yeah.
Well, I think this is particularly important for inpatients, right? But actually, if it comes to outpatient and then also follow up in outpatient clinics, I think then the scenario would be a little bit different. Then maybe also just a question to this. So, for example, if I would like to start to also get to know a little bit about the sleep apnea status in my patients, do you think it's necessary to send everybody to polysomnography, or are there easier tools? Olaf, you already mentioned apps now in this COVID pandemic. Well, apps are everywhere. So questionnaires that do not seem to work. So this is also what Jeroen, of course, mentioned. Olaf, how are you, for example, now testing for sleep apnea in your patients at the moment?
Still using polygraphy screening, so that we know what's the relationship between central and obstructive and mixed apneas and so on. So I think that's enough. We don't need polysomnography. So, but at least we need some 4 or 6 channel polygraphy screening. That's good enough. And maybe before that we can do a little pre-screening, because as said, validated questionnaires are not existing in our patients. So we have some risk factor. We can ask about BMI and neck circumference and so on. But we do not have really specific symptoms in our cardiac sick patients. So maybe some apps will work in some kind of pre-screening. But again, we need, what's the consequence? What's the consequence? The consequence is if we identify obstructive sleep apnea, either we change ablative strategies and looking for extrapulmonary vein foci or so on, or we treat the sleep apnea, and we need proven benefit for both of it.
Absolutely. And I think this is also actually a very important point. Well, there's still a lot to do. This actually relates to how to manage the patients, but also, of course, how to treat them. Sleep apnea treatment might be the best in some of them, but on the other hand, also we know that not all of them could be treated, and we do not have the data yet that treatment alone is sufficient, meaning also that new ablation strategies might also be a very interesting way to go there. There are some also devices developed at the moment. There's medication developed. So we have really a lot of tools in this area in the future to do the randomized trials, like Olaf actually said, which we finally also need, of course. I think just to summarize this a little bit, sleep apnea is highly prevalent in patients with atrial fibrillation. Whether all of them need to be treated now, or actually if patients can profit from this, we need randomized controlled trials for that, to also identify those patients who can profit without doing harm. There's no validated questionnaire at the moment available. Like Olaf said, polygraphy might be the way to go at the moment to get quickly an idea about the status of sleep apnea in our patients. Also still distinguishing between central and obstructive sleep apnea, which seems to be important. And isolated sleep apnea treatment, this is probably not the way to go. We need to have like integrated care approaches, combined approaches, and also within an interdisciplinary team like Jeroen actually nicely presented. So thank you very much for listening, and see you soon. Bye.
Thank you.
Thank you.